Good afternoon. Thank you very much for the invitation.
I'm learning, but the Andalusian version of Spanish sounds very fast. I have good news for you. Since I'm not a native English speaker, my English is very clear and very simple. So you might understand it also without translation. And good news is also that the first topic, my talk, is a very an overview, one about the lumbar spine and about the movement control, and the colleagues afterwards are going much more to detail. And I think we are looking forward to a very interesting session this evening. I heard very nice positive feedback from my workshop yesterday, and I saw all the Twitter notices, so it's really nice to see that people are very interested in this topic and very enthusiastic. So what's better for a speaker than enthusiastic and motivated listeners? More good news, or maybe at first the bad news. We have huge problems with back pain. Back pain is the most costly health problem in our modern societies. And what's peculiar that all the other illnesses, let's say heart diseases or cancer and everything, is going a little bit back. But back pain and neck pain is increasing. It's a bit funny thing because we have always more doctors, more physios, more chiropractors, and the more we are, the more we have also the problems. So in a way, somehow we ourselves are a part of the problem. And actually, the guidelines of low back pain also reflect that. For example, we know that discogenic and structural findings cannot differentiate who has back problems. So the structural findings are not important. However, I think when we look how our health systems are working, the diagnoses are mostly based on the structural findings. At the same time, those are not interesting, they are not important, and that's why 90% of low back pain is said to be unspecific. And unspecific means only there is no structural cause or medical diagnosis explaining this back pain. And because of this, the X-rays and MRI scans and so on, they are not recommended by acute low back pain. However, I think we see it all the time, every day, all the back pain patients coming with their findings. I have the bulged disc. And actually these discs don't have to mean anything, but what it causes is fear and catastrophizing, and maybe that's one of the biggest problems. At the same time, also the evidence for medical interventions is very modest. So medication doesn't seem to help, at least not in the acute low back pain, and in chronic low back pain, even less. Surgery is not an option. It's maybe 1 or 2% out of 100 who need surgery. So what is the recommendation? And this is good news. The recommendation is quite clearly the functional examination, the clinical examination, and then the functional treatment. And I think this is a good card for physios, because I would claim that this is the area of physiotherapists doing this functional examination and treatment. So the first question is, if 90% of low back pain is unspecific, is it really so? Or should we try to classify them? Should we try to subgroup the people? This is one subgrouping system, and I really like this system of Peter Sullivan. There are others, Nick Karayanis will talk later about other subgrouping systems, and we'll see the differences and similarities in these systems. However, the system of Peter Sullivan has been shown to be very reliable and also very effective therapy. I'll explain it shortly. So it would be that the smallest part, maybe 5 or 10% of patients really have a specific problem in which the structural finding or the medical diagnosis really explains the problem. And that would be like fractures, tumors. The most important one is the nerve root affection, where you really have a clear numbness, motor loss of one segment, which is easy to diagnose. And also there, the most important diagnosis is the clinical diagnosis. And then we have spinal canal stenosis, which of course everybody gets. If you get old enough, everybody has spinal canal stenosis. And the question is whether it starts with 70 or 75 or at 80. And it's just normal degenerative changes. And interesting is to know that even here it seems that physiotherapy is as effective as surgery. It's quite amazing how effective physiotherapy can be. Okay, and then we have this huge group of non-specific low back pain. We could at first think whether the back pain is mechanical or non-mechanical. And quite clearly, back pain is mechanical if the patient can clearly say it's this movement that's hurting, or it's this movement where I'm restricted, so then it's clearly mechanical. Or it could be also postural. So certain posture, sitting for a long time, standing, staying in the sustained postures causes the pain. And when you leave the posture, the pain is away. So that would be mechanical back pain. I think the most difficult group is the non-mechanical back pain group. So these are patients who say, my back is hurting all the time, or I can't say what's causing the back pain. The pain is doing what it wants. It has a mind of its own. And I think this is an important group because these people have the greatest risk of chronification. And it seems, in the light of evidence and studies, that we are quite poor in acknowledging the psychosocial factors. So the first thing is that we start to sensibilize ourselves with the psychosocial factors. That's fear avoidance, that's catastrophizing. So it goes like, if somebody thinks, because my back hurts, something must be broken. Because something is broken in my back, I have to be careful. So in these cases, if you don't get this mindset changed, the situation won't change. It doesn't matter what kind of exercises you give, this mindset is the problem. So we have to be very careful here, and I think we have to learn quite much here, acknowledging and also how to treat these patients. The mechanical group is an easy one, because those one with movement impairment, they have a restricted movement, they have pain in certain movement, they are quite easy to treat. In most cases, they are also quite acute patients. So here we can use manual therapy, we can use myofascial release, fascial techniques, trigger points, no matter anything. If you acknowledge which structure provocates the pain, it's quite easy to treat. And the last group being this movement control impairment, which is also quite an easy group to treat. However, at first you have to notice which direction, what is the problem, what are the tests, and what are the exercises. So I will concentrate in this subgroup of movement control impairment. You could say also this is the postural kind of back problem. Some patient examples. Let's say, for example, the first one on the left, this patient is trying to do a test, waiter's bow. Can you bend forwards without moving your back, just moving in your hips? And it looks like this. Can you put on the first video? So he's moving, but he's moving only in the back. so his hips are not moving. And you have the feeling he doesn't understand what I mean, so I repeat, I explain, I show him what to do, and he doesn't seem to be able to get the movement right. So he has a flexion control impairment. He can't control the flexion movement. He's flexing too much in the lumbar spine. And for example, this patient is working in constructions of building sites. So if he can't do this very simple exercise correctly, you can imagine what's happening all the day when he's working. In the second video, on the right, the person is trying to do a pelvic tilt, backwards pelvic tilt. And it looks like this. Can you put this video on? He's going forwards. No, I mean, can you tilt the pelvis? No, he's going backwards. And he's doing everything but not what I asked him to do. So in a way, it seems that he doesn't understand where the pelvis is. Lying in supine, it looks he's doing something with his stomach, but he's certainly not moving the pelvis. So in a way, his central nervous system seems not to know where the back is. Lying prone, when he's bending the knee, you can see that the back is moving as well. And if you ask, did you feel your back moving? He would say, no, I didn't notice anything. So in a way, he doesn't seem to be aware of what's happening in his back. In the next video, the person is trying to, in all fours, to go back with his pelvis towards the feet. And when he's doing it, can you start the video and stop when I say this video here? And can you stop it here? And when I'm asking him, well, is your back now straight? He says, yes, I think so. Then I show him this video, and he's asking, hey, what's coming out of my back? And I'm saying, well, that's your spine. That's just something he's not aware. And this is quite a typical case of patient going to doctor. The doctor doesn't find anything. He has full movements, he has good muscles, he can do everything. But he gets back pain when he's working because he's a lumbar. He gets back pain when he's sitting longer time in a car, when he's driving car, and so on. And nobody ever told him that he doesn't seem to be able to control his back. And this is very easy to treat. You put a tape in his back, and he won't flex anymore in the back. So he has to learn to use his hips. But of course, if nobody notices this and nobody tells him that, he won't correct that. The last video is a young guy, 14 years old. He's sitting straight, and he should just extend his knee. And let's see what happens. Can you play the video? So we can say that his back is flexing, and he has great difficulties to control this movement. When he's doing just a normal squatting, it looks very difficult for him. It doesn't hurt. It's just that for him, it's almost impossible to do. And you can think, if you have such difficulties with 14 to make such an easy movement, how will that develop? Okay, that was maybe 15 years ago when I started to see these kind of patients in my practice. And I had learned from Shirley Salmon that you can examine these people. She has developed 28 different tests for movement control of the back. And I was thinking 28 tests is too much. So if you have to do 28 tests for movement control and then maybe another 30 tests for SIJ and for facet joints and disc and everything, you will have the whole day in examining. So we were thinking maybe we should try to create a very simple, a short version, a test battery which would give an impression how the movement control of the patient is. So the tests are: the weight is bow, can you bend forwards without moving your back? If the back is moving, you get 1 point, the test is positive. Can you tilt your pelvis backwards? Those people who can't, they are doing something else, for example, like this. So in a way, they don't seem to have this pattern of movement. The third test is sitting knee extension. Can you sit with straight back and move your leg without moving your back. If the back is moving, the test is positive. On one leg stance, we look whether the belly button is moving more than 10 centimeters laterally. If so, the test is positive and you have a control problem in the lateral flexion. And then in all fours, can you go backwards and forwards, moving only in your hips and keeping your back straight. And the last test, prone knee bend, can you bend your knee without moving your back? So we get a score from 0 to 6. The more tests positive, the poorer your movement control. If you get 0, you could do all these simple tests correctly. And we looked for the reliability of these tests, and physios can quite reliably examine these people. Then we looked for differences between healthy controls and people with back pain. And you can see here in the red columns are the healthy people. So the typical score by people without back pain is 0. So they could do all the tests correctly. The typical score by back pain patients is 3 or 4 positive tests. If we calculate the odds ratios for 2 or more positive tests out of 6, we get odds ratio of 8, meaning that if somebody has 2 or more tests positive, the chance that this person has back pain is 8 times higher than that he wouldn't have any back problem. Then we started to think, well, how come is it? Why do these people seem not to be able to control their backs? And we started to think, well, maybe it's something with body awareness. And there is quite an old study, and there are some evidence showing that by chronic pain, the representation of the body in the homunculus, in the sensory cortex, is changed. This is an old study from Hertha Floor in Germany, who showed that by chronic low back pain, the representation of the back is in a wrong spot, meaning that the brain doesn't know where the back is. So if the brain doesn't know where the back is, how could the brain control what's happening in the back? So there is a very simple way of testing the body awareness. We can roughly say that this is a quite valid, but anyway, a very simple way of testing the body awareness, and that's 2-point discrimination test. So you tap with this caliper ruler 2 points, and then you always go more narrow with these points, and the last 2 points that the patient really acknowledges that it's 2 points instead of 1, that's the 2-point discrimination. So we looked, 90 people, half of them with back pain and half of them without back pain, and we saw in this sample of people, healthy people had now 1 positive test in the movement control test battery, and low back pain had 3 positive tests, and in 2-point discrimination, the healthy people had in average 4.4 centimeters, and the back pain patient averaged 6.1. In the meantime, we can say quite well that in 2-point discrimination, everything above 6 centimeters is not normal. So it's a very practical test that you can use immediately starting on Monday. And once in a while, you are astonished how you get patients who might have like 2-point discrimination of 15 centimeters. So if the brain thinks that these points are just 1 point, then anything that happens in this area, the brain doesn't have any idea what's happening there. And it seems that these 2 things, the movement control and the 2-point discrimination, correlate quite nicely. So obviously, they have something to do with each other. Then we looked whether we can treat this movement control impairment. So we took 40 back pain patients who had at least 2 points positive, and we treated them roughly about 10 times individually, and we tried to improve their movement control. And we got very good results. So the movement control got from 3.2 points down to 1.3. Roland Morris Disability Questionnaire improved really significantly, and the patient-specific functional scale as well. So, in a way, if somebody has a movement control impairment, we can treat it, we can change that. However, here we didn't have any control group. I'll tell you at the end of the speech of some RCTs which we have conducted by now as well. But maybe at first, let's have a look of these different directions of movement control impairment. So, like we saw this person already, he has problems in controlling the movement in the flexion. So when he's moving, the movement is happening in the back. Let's see the second video here with this lady when she's doing the same test. So the waiter's bow. Can you play the video here with the lady? No, the second one. Yes. So we can see that nothing's happening in the hip, but she's moving only in the back. She's always also a little bit hypermobile. When she's correcting the movement, you can see it doesn't seem very natural. So she has great difficulties to keep her spine in neutral. Somehow, it's very difficult for her. And we saw already this young guy who has also flexion control movement impairment. In the extension, we saw already this gentleman here who couldn't tilt his pelvis backwards. So typically, the people, they try to do something else, but exactly this pelvic tilt, they don't get done. Let's see the second video here. Lying in prone, this person, can you play the second video here? You can see some extension happening here on the right side and on the left side even more. And he can't stop the movement in the back. And if you ask, did you feel the back moving? He would say, no, I didn't. In rotation control, we looked at the one-leg stance test. So like in this first video, can you play the first video, please? You can see in one-leg stance, this lady is going well above the 10 centimeters. She's somewhere by 13. So you can stop there. Thank you. Okay, so the other direction is the same. Yep, that's fine. Thank you. And in the second video, this person is doing it in flexion. Can you play the second video, please? You can see that the pelvis is somehow rotating quite funnily. And in the last video, can you play the last video, please? When this patient is flexing the knee, on left side he has an extension give, so the movement is happening in extension, and on the right side he has rotation. So there is a rotatory movement happening, and very typical by these cases, the people are not aware of this movement, what's happening. Okay, maybe let's have a look at what kind of exercises for which kind of movement control dysfunction, because I believe, I don't know, maybe 95% of you are practicing physios, and in a way you want to know what to do with these patients. The flexion control impairment is maybe the easiest to treat. So if everything is otherwise fine and it's only a flexion control impairment, it's quite easy to treat. You can use tape. A key issue, a key exercise is squatting. That the person learns to squat with straight back and using his or her hips. You can use also the test positions to train. When they get to control correctly, you can put some weights, you can start loading, you can also really train their back muscles, so you can do quite hard stuff as well. And of course, stretching or lengthening in these flexion type people would be stretching the hamstrings or gluteus muscles. In many cases, these people have this so-called relative flexibility. So the hip is in relation to their lumbar spine stiff. So the hip is not passively stiff, but in relation to lumbar spine, the lumbar spine is moving more and the hip is in relation stiff. For the extension control, which is also quite easy to treat if you have only this problem. Of course, it gets more difficult if you have flexion and extension. And if you have also rotational problem, then it's of course a bit more difficult and needs more time to correct. By extension control, the main exercise at first is just to get the buttocks muscles going and learn this pelvic tilt and the activity of gluteal muscles. In many cases, these people are using just their abdominals. That could be also people doing a lot of Pilates or training and so on, and they are always using their abdominal muscles, but their buttocks they are not using at all. So you can use different starting positions for this pelvic tilt. When they get the control going, you might start also lifting the whole leg and keeping the back in neutral, or you could try to keep the back in neutral and move your arms. And then when you get the control, you can start to strengthen the muscles. In these cases, gluteal muscles are very important. Iliopsoas could be weak. So you might be training iliopsoas muscle. And also the lower part of abdominals might be weak. To stretch, you might be, it might be important to stretch the rectus femoris muscle, maybe the upper part of the abdominals, and maybe also tractus iliotibialis. For the rotation control, the main exercise to learn is one leg stand. And of course, you have seen a lot of people, a lot of patients, and a lot of people have great problems with one leg stands. And if you make it a little bit more difficult that they have to also lift the other leg, you might see that they start to, that they really have to search the equilibriums. So they might be try to lateral flex the upper part of the body and keep their belly button on spot, or in different starting position, moving their hips rotationally, but keeping the back in neutral. So that might be on side lying, prone lying, or supine lying. All actually exercises from Shirley Sarman, and of course this is not rocket science. These are very simple exercises. However, these exercises are specific for that particular direction. So if you don't have any rotational any rotational movement control dysfunction, these exercises are not important. If you have extension type of problem, the flexion control exercises don't bring you anything. So it's direction specific. By rotational one, the strengthening, of course, very important is gluteus medius muscle, quadratus lumborum, the oblique abdominals, all as well very well-known exercises, very typical exercises. Stretching with these patients might be important, tractus iliotibialis, maybe piriformis muscle, maybe iliopsoas muscle. Okay, I promised you to show some randomized controlled trials. So now we know we can examine this group, we can find out the group who has movement control impairment. And we know we can treat them, and we know we can get good results. However, that's not enough. If we can isolate this group of people, the next step is, okay, we'll get this group of people and we randomize them in 2 or more groups, and we give them specific exercises and general exercises and see whether it's better with specific exercises. So there are already few of these studies. We have conducted ourselves 2 RCTs. This is our Swiss version, where we had 106 patients who had at least 2 positive movement control tests. We had 13 private practices and 28 different treating physios. And one group was getting specific movement control exercises, and the second group was getting general exercises. General exercises meaning buttock muscles, stomach muscles, back muscles, stretches, but everybody the same. Interestingly, all the people got much better. So at 12 months, they were really much, much better with their back pain, in function and in pain. But there was no difference between the groups. The only difference that we had was short time in 3 months. And we might think, well, why is it so? If we have a specific problem, it seems to be that it doesn't, the exercises don't have to be so specific. Well, when we asked the people after 12 months, are you still doing your home exercises? And in both groups, 80% of the participants were claiming that they would be still doing the exercises. So maybe if they really have such a good adherence and they really train the muscles, it's also good. But at least in short term, we get better results with specific exercises. We have conducted exactly the same study in Finland at the same time, different patients, different people, different therapists, with this exactly the same setting. However, we got significant better results for the specific exercise group. The biggest difference between these studies is that in Finland, one therapist was doing all the therapies in the specific group and another one in the general exercise group. Colleagues in Sweden have done also similar kind of studies, so they also isolated at first this movement control impairment group. So they looked at, they had 2 or more positive tests in this test battery, and then they randomized them in high load lifting group versus low load movement control exercises. They had significant better results for the specific exercises. In the States, the group of Shirley-Salmon did also very similar study. So they also isolated the group with this problem, and they randomized them in 2 groups. So they had the matched treatment or unmatched treatment. However, all the people got better, no difference between the groups. And the best study to show that subclassified people do better than not subclassified people is the study from Norway, from Kjartan Fersum, who had really enormous, much better results for those people who were at first subclassified and then treated for their subclassification. And these results are for the group of movement control impairment. So we have both. We have positive and we have negative studies. Altogether, it seems that these people need exercises, they need training. No one looked whether passive therapy would be better. I doubt. I think they need training. But currently, it seems that even if they are doing just general exercises, the main thing is that they have to do the exercises and for a longer period of time. However, me myself, I'm a little bit going away again from this subgrouping because I think brain plays a big role in low back pain. So we have to look for the cognitive factors, fear, catastrophizing, hypervigilance. So we have to explain to people neurophysiology of pain and so on. We have to look the body awareness, sensory level, and then also the motor control. We have conducted so far 1 RCT, a small one with 28 patients, where the specific group got all this whole package: explain pain, sensory exercises, body awareness exercises, and motor exercises. And already in this small sample, we got significant reduction of pain compared to individual manual therapy with exercises. So, putting it together, low back pain is at the most a functional problem, so we have to examine it also functionally. We can treat this impairment very well. It's a clear, specific subgroup of back pain patients. However, this body awareness and cognitive factors need very much attention to. Muchas gracias.